Dr. Z, welcome to Neurosurgery Tales. I'm truly honored to have you here today and discuss your journey and everything that you have built. You built on of the most visible neurosurgical presence online, and yet you speak from a place of introspection, honesty, and discipline. So today I would like to explore with you that space in between, the tension between being a high-performing neurosurgeon and a human being who feels deeply, who questions, and who shares so much like you do.
Yeah, thank you. No, I appreciate that. A lot of what I do is really just trying to show people what it's like to be in the world of neurosurgery. Neurosurgery varies based on your role, whether you're a
Mm-hmm.
resident, whether you're a fellow, whether you're in a PAs, NPs, nursing,
Mm-hmm.
all that stuff is going to be very different. And your role, your day-to-day, it's not going to be the same for everybody. So
Mm-hmm.
sometimes one neurosurgeon might see my day and say, oh, my day is busier than that. Or they say, oh, why is this guy working so much? You shouldn't be working that much. It just depends on who's looking at the video. The videos that I've made so far were either me in residency or me in fellowship, thankfully. And
Yeah.
that's usually when you work the hardest. That's usually when you have the most amount of hours dedicated. But thankfully, I'm through those two stages of my life. Right now, I'm an attending, and my official job is going to be starting in a few weeks.
Mm-hmm.
And excited to kind of showcase the day-to-day from that aspect. But it's a huge transition to go from
Mm-hmm.
residency fellowship to being an attending. It's a massive change. It's a huge leap forward. You're taking on a huge responsibility. And everyone tells me that it's going to be very different once you're an attending. The amount of, I guess the amount of, I want to think of the right word, the investment, that's the word.
Mm-hmm.
Investment that you put into one particular case is going to be mountains more
Mm-hmm.
than what you would put in if you were a resident or fellow. And I can't explain that yet because I haven't gone to that step yet. But I know my
Mm-hmm.
first as an attending is going to be one that I'm going to remember forever. So I'm eager to get started on that.
Yeah. Do you feel some kind of relief that you finally finished residency and training and now or it's different?
It is such a relief. I honestly, let me tell you this. When I
Mm-hmm.
signed my contract, my first contract to be a resident, it was
Mm-hmm.
2017.
Mm-hmm.
And the contract for residency extended for 7 years. So when I signed the contract, it was June 2017. I remember looking at the contract, that June 2017, and the end date of the contract was June 2024.
Mm-hmm.
And in 2017, looking at 2024, I just couldn't wrap my head around that number because I started when I was 26 years old. And I was like,
Yeah.
I'm going to be 34 years old when I'm done. And I couldn't wrap my head around that. I really didn't think I was going to live long enough to see 34. I don't know why, but I was like, who knows what's going to happen in 7 years? But it
Yeah.
seemed like such a long distance, such a long time frame away. And when that day came, was arguably the most memorable day of my entire life because that was the culmination of genuine blood, sweat, and tears that all
Mm-hmm.
went into this training where I dedicated my entire life to being able to serve humanity. And that's really what I wanted to do. And sometimes people don't really recognize that, is that doctors and neurosurgeons especially, just because the residency is so long, the dedication that you put in is truly one that is invaluable because you're putting in
Mm-hmm.
youth, you're putting in your time, you're putting in your health. Those are the healthiest, youngest years of your life.
Yeah.
And you're sacrificing those, staying up late, 100-hour work weeks, even more than that sometimes, exhaustion, emotional distress, mental distress, and just overall stress in general, poor sleep, poor exercise, poor nutrition, all that stuff takes a toll on you physically, right?
Mm-hmm.
So you're sacrificing so much during that time. And the short answer to your question, I guess, is yes, it's a huge relief because I'm glad that part of my training is over.
Mm-hmm.
But it's still going to be a very difficult road ahead because the real work is now starting. Now I'm going to actually be able to apply everything that I've learned for the past 8 years in surgical training and the past 11 years in medical training and the past 16 years in education that I've had going towards medical training stuff. So I'm eager to kind of implement all that stuff.
Yeah, that's a really, really long time.
It is. It is an exceptionally long time. And obviously not all specialties are like that, right?
Mm-hmm.
Depending on what type of specialty you do, it could be 3 years, it could be 7 years. But then after the 7 years, you still have a fellowship that you can do. And I decided to do a fellowship because why not? So I did this much training already. What's one more year? Might as well do an additional year. So I did that extra year of training, which was in complex spine surgery. I was able to do that in California, and great time doing that last bit of training, and it really kind of solidified and reinforced all of my existing surgical abilities. And yeah, now it's time to hit the road running.
Now, 16 years ago or like 8 years ago, what was the precise moment you realized you want to become a neurosurgeon? Like, this is your calling?
No, actually, since I was 11 years old, I wanted to be a cardiothoracic surgeon. I have a yearbook from my 6th grade graduation from elementary school when I graduated from 6th grade to 7th grade, because I lived in Canada for a short period of time, and high school started in 8th grade. So I guess that would mean it was my 7th grade yearbook. So my 7th grade yearbook, future occupation is what we want it to be. And obviously people wrote down all sorts of stuff. And I still have that yearbook in my parents' house. And that yearbook, the occupation, it said future heart surgeon. And that's what I always wanted to do, was heart surgery, because it said future blank. That's for every student. Future this, future this, future this. And for me, it was future heart surgeon. So I wanted to be a heart surgeon for the longest time. And then I got into medical school. I was going to be a heart surgeon. This is it. I'm going to do it. And then rotations started when I was a second-year resident. And when rotations started, I did heart surgery rotation, cardiothoracic surgery rotation. And then it was great. I had an awesome time. And then I did a neurosurgery rotation and didn't even come close. Neurosurgery was just so much more exciting to me, like not even close. And I guess that's how I knew that's what I was destined for, was for neurosurgery. That really got me excited. When I was doing cardiothoracic surgery, I wasn't eager to get into the operating room. Because I mean, as a student, you don't do much anyway, but
Yeah.
I was regardless, I was still really excited to go to the OR when I was my neurosurgery rotation. And that's really when I knew it. But also my dad needed spine surgery at one point, and he had his spine surgery done. The surgeon that did his spine surgery told me I could shadow him anytime I wanted. And I was a medical student at that time. So I shadowed him for a day. And I remember the first neurosurgery case I saw, it was something called a neuropace. And it's basically a device that monitors electrical activity in the brain. Senses that there's going to be a potential onset of a seizure. It can release an impulse to kind of override the epileptic initiation signal. And so it can override the epilepsy to prevent it from happening, or it can kind of monitor the epilepsy if it's happening. So that way, when you come see your doctor next time, they can see exactly what happened, what the signal was, and all that stuff. And I remember seeing that, and I thought it was the coolest thing ever, because you put a chip inside someone's head and you're monitoring their brainwaves. And to me, I was like, this is crazy. You're like making cyborgs. I thought it was the craziest thing. It's like Neuralink, what Neuralink is today.
Yeah.
Neuralink is a much different thing. It's very advanced. It's very complicated. But NeuroPace was kind of what intrigued me a lot in the beginning. And I would say that's kind of the moment that I realized I wanted to do neurosurgery, is when I was excited to go into work as a medical student. So I could see how neurosurgery is done.
And you also shared how a surgeon once told you your class not to pursue neurosurgery, and you pushed toward, and it kind of pushed toward it.
It's a culmination of things, many things that really pushed me towards neurosurgery. That is one of them. So one guy, so it's funny, the guy that said not to do neurosurgery was the same guy that did the surgery for my dad. Same
Oh,
guy. I ended
okay.
up messaging him after he gave us the lecture. I sent him an email. I said, "Hey, listen, my dad needs spine surgery. We can go to an orthopedic surgeon or we can go
Hmm.
to a surgeon. But since you came, you talked to my class. I want you to take a minute to look at the pictures and look at the MRI. Let me know if there's anything you can do." And same guy who told me not to do neurosurgery, ironically, was the inspiration for me to do neurosurgery. And he made my dad be able to walk again. And he gave my dad the gift of being pain free for the rest of his
Hmm.
life. Now, of course, not all spine surgery is like that. I can talk
Yeah.
about spine surgery all day if you want me to, but not all spine surgery is like that. It really, the goal of spine surgery is to reduce pain, not to eliminate pain. My dad, thankfully, was just one of the few where he had his pain be eliminated, but I would say that's the exception, not the rule.
And with all your career and like rich experience you had, what was your first real moment of doubt? How did you get through it? Because it can hit you like,
Moment of doubt. I would say the biggest moment of doubt was when I took my first night on call, where I was genuinely scared. I've never admitted that before, but it's true. I was actually scared. And the reason why, I'll tell you why.
hmm.
Why is because for the first time, I was the only neurosurgeon left in the hospital by myself. I was the only neurosurgeon available for that time frame. When you're on call as a resident, there's only one neurosurgeon in house because there's so few of us. There's no need and the resources aren't there to have multiple neurosurgeons in house overnight at the same time because work hour restrictions and all that stuff means that you're post call the next day, so you don't come in the next day, which means that there's less surgeons to do surgery the next day. So
Hmm.
the way that it was set up at my institution and the majority of institutions in the United States is if you're on call at night, you are by yourself. And for me, I was the only neurosurgeon in that hospital for that time frame by myself. That's it. I was the guy. I was the neurosurgeon. And that was the first time where I was actually very, very nervous. And I started to question whether or not it was
Hmm.
like, can I handle whatever comes in the door? Now, of course, I want to make it clear to you and to everybody that's listening. Some people, if you're in medicine, you understand that I can call the attending and just say, hey, listen, there's this case. I don't know what to do. I need your help. They can help me.
Hmm.
But those same people should also understand that if you pick up the phone and you call the attending, you better have a damn good reason why you're calling them at 2:30 because they don't want to hear your voice at 2:30 in the morning, right? So it was terrifying because I could call for backup, but I also had to know when was the right time to call for backup if it was needed. Also, if there was an emergency and there's nobody here, I have to manage that for the time being until someone more senior can come.
Hmm.
That was the moment where I kind of was terrified and I said, can I actually do this? And there was a picture that I posted on my social media where I said, I worked 30-hour shift and then I came home and I collapsed. That was that day. That was my first
Oh.
night of being on call. I forgot to write that part down where I said it was my first overnight call. And it was that night. And I came home. And so I did it. I
Hmm.
successfully did it. Emergency came in. I made the right calls. We had a case that night. I did all the consults. I did everything. I did it successfully, but I was brand new. I was a second year resident. And it was my first time being alone. And I got through it and I did well. And my seniors were proud of me because it was a busy night and I still got everything done correctly. And then I came home and I didn't take off my scrubs. I just literally collapsed on my mattress. And I woke up after I collapsed on my mattress and I was sweating because it was still during summertime. I didn't turn on the AC. I was exhausted. I was sticky. I felt gross. And I looked at my phone. I had like 35 missed calls. My parents were trying to call me, trying to figure out how my first night went, all that stuff. And when I got through it, that's when I really realized that, hey, you know what? Maybe I can do this. Maybe I can. That was one time. The other time was when I was taking my boards, my written boards. When you're
Hmm.
doing neurosurgery, you take two boards. You take a written boards and you take an oral boards. The written boards, I was absolutely terrified of because that is a objective measure of how much you know about neurosurgery. And
Hmm.
that will determine whether or not you have what it takes to continue your residency training, to graduate, to be a
Hmm.
neurosurgeon. And I was really, really terrified of that test. But I studied so hard for that test. And I don't know how some people don't. Some people can get away with not studying very much and they can just do that. But for me, I spent hours and hours and hours every single day. I didn't take a break. Every single day, 7 days a week, I was studying for that board's exam for about 2 years, for hours. And I took the board's exam and I did exceptionally well. And I was so proud of myself because all that work paid off. And I got to tell you, I've never felt smarter in my life than after that test. Because I was like, wow, I did really well. I know everything there is to know about neurosurgery now, which of course is a delusion, but I was really proud of myself at that time. So going into the test, I was doubting myself. After the test, when I got the results back, it said passed. That's kind of one of the moments where I said, you know what? It's not that I think I can do this.
Mm-hmm.
It's that those people that administered the test all sat down at a table, looked at my test results, and said, this guy knows enough to be a neurosurgeon. Those
Yeah.
guys, the American Board of Neurosurgeons, thought that I can do it. And then in that moment where I said, you know what, it doesn't matter what I think. The American
Mm-hmm.
Board of Neurological Surgery thinks that I have enough knowledge to be able to get through residency so that I can start practicing and then take my oral boards. That is when I kind of took a sigh of relief. And I said, you know what, maybe I do belong here.
Yeah, when someone from that level tells you that you are smart or you can do it, that's
That's it. You feel like you made it. You really do. You feel like you accomplished it. And it's, again, it has nothing to do with your inner voice. I have a
Mhm.
very toxic inner voice, unfortunately. My inner voice always tells me I need to do better. That's my inner voice. And I like to think sometimes that is the reason for why I am where I am today. It's because that inner voice always tells me that I'm not good enough, so I need to work harder and do better. I need to work out harder. I need to eat better. I need to sleep more. I need to also work harder. I need to do more surgeries. I need to do more content. I, I'm always thinking about that stuff in my head, right? But for once, that voice doesn't matter because people whose decision it is to determine whether or not you are good enough said you are good enough. And that made me feel better.
And you also said you're an introvert in one of other interviews, and yet you're one of the most visible neurosurgeons online. Where do these two selves meet?
So here's the funny thing. I have friends in medical school that reached out to me and were like, you are the last person I would have guessed would be inclined to create content for social media.
Mhm.
Because in medical school, I was shy, awkward, quiet. Honestly, I still am. I'm still very much quiet. I'm still very much reserved. I don't like having conversations with people. This is very different. Just to be clear, this is very different. But like, what I mean by that is I don't like my worst nightmare is sitting in an Uber and then the driver asking me, would you have any plans for the week? Any
Oh,
plans for
yeah.
the week? It's so benign. It's such a simple question. Anybody can
Mhm.
answer that question. It's fine. But to me, it is just like, I just can't, I don't enjoy that conversation. I don't enjoy it whatsoever. Some people, my brother, for example, is a huge extrovert. He loves talking to strangers. It's not for me. I just don't like it. I'd rather just be kind of, headphones in the back of an Uber, laid back, eyes closed, waiting to get to where I need to go. That's really what I like. But even though I call myself introverted, I understand that the position that I'm in requires me to interact, communicate,
Mhm.
be exposed to the public, and I take that responsibility very seriously. So, of course, I'm never upset, annoyed, or irritated when somebody wants to talk to me or anything like that. And obviously, I take that very seriously with my patients because I have to have very serious conversations with my patients. So, I learned to kind of adapt to the situation. But if it was up to me, I would just be by myself in my apartment all the time, left alone.
I was about to ask you, maybe that was because of the culture you grew up in, but you then said your brother is an extrovert.
Yeah, my brother will talk to anybody. It's wild. Definitely not culture. He's in sales. He does a lot of sales and recruitment stuff. And he is, I have no idea how he does it, but he is incredibly talented at what he does. And when me and him are together, we go
Mhm.
out and he's the one that is talking all the time. And I don't say a word. I just sit with my brother because he's my brother. And I sit there and I'm quietly eating my meal, drinking my drink, having a good time with my brother. He is talking to everybody. And I admire him for having that skill set. It's just not for me, but I really admire him. But anyway, I'm sorry. I interrupted what you were saying. You were saying something.
Yeah, so I'm from Eastern Europe, so in our like we don't do small talk. It's very awkward for us, and we don't talk a lot. So it's not because we're don't like you, or but because it's just our culture. We're not like
Yeah,
so.
no, I can definitely understand that. I've noticed that like one of my mentors
Hmm.
in residency is a Russian individual who is a phenomenally talented spine surgeon, just an incredibly gifted surgeon. This man has no time for small talk. This man has no time for pleasantries. He is very much to the point and is the type of individual that wants to be left alone as well. But
Hmm.
he gets his message across, and then it's end of conversation. That's it. So I know other Russians that are also like that. So sometimes I like to, I think that some of that might be cultural as well, but who knows?
Yeah, probably. In the operating room, what's the one thing that always reminds you, this is why I'm here? Like, this is why I want to be a spine surgeon.
It's going to sound selfish, but I'll tell you
Hmm. Yeah.
the reason that I really enjoy surgery is because when a surgery goes well,
Hmm.
you are on cloud nine. It's like a high. There's like a euphoria from
Hmm.
doing a surgery. And when the patient does well, you get goosebumps, you get chills. Because I remember very vividly there was a 38-year-old that had a tumor on one of their nerves, and
Hmm.
this person couldn't move his arm anymore. And I took out that tumor. My attending was in the room, but I remember I was the resident, and I did that entire case from start to finish. He was scrubbed in with me. He was watching me,
Hmm.
and I did that entire surgery from start to finish. He didn't do anything. And
Hmm.
I took out the tumor, and I closed up the patient, whatever. He woke up immediately after he woke up. None of us were expecting him to move his arm because it's been
Hmm.
like that for a long time. When he woke up, he was almost full strength in his arm, and he started crying. He was like sobbing,
Wow.
so happy. Uh, that stuff like that, when the surgery goes well, you're efficient in surgery, the
Hmm.
patient does well, there's nothing that can bother you for the rest of the week or the month because you just feel so good knowing, hey, I gave this guy his life back. He didn't have his arm, and now he can pick up his daughter. Like that is
Yeah.
one of the things that really makes me happy. So that is something that in the operating room I would say, okay, this is why I do it. On the flip side of that coin, it's the opposite. If something doesn't go as
Hmm.
planned, uh, it's the opposite. You are miserable for the rest of the week, and then you start to doubt yourself, and then you start to question, is this for me? Should I even do this surgery? You start to question whether or not this was the right thing to do in the first place. But yeah, those moments are rare, thankfully.
Hmm.
Moments that when patients do well are definitely the ones that are more common. And those are the ones that are very impactful.
Yeah.
And the not so good outcomes, for some reason, even though they're so rare, they have a more powerful impact on your state of being than a positive outcome.
Yeah. And you also talk about openly about the fear of being a mediocre surgeon. And I think like everyone has this. This is like the biggest fear. What does that mean to you specifically?
First of all, I'm incredibly flattered that you heard all these things that I've said, and that's very nice of you to do your research. So thank you for
Yeah.
that's very nice of you. So, okay. So yes, one of those things was the fear of being a mediocre surgeon. So I'll tell you what I mean by that. When I was a resident, what I just tried to make sure that I could get into as many surgeries as possible, as many as I could. And the reason why is because I thought to myself, now when I'm an attending, what am I going to do when I'm in the operating room and I'm the attending and I don't know what to do? That was
Hmm.
so terrifying to me. And that's not even being a mediocre neurosurgeon. That's being a untrained, unskilled neurosurgeon. So that
Mm-hmm.
wasn't an option for me. I wanted to be skilled, but being mediocre means you have longer OR times, your outcomes are not as good, your patients wake up with deficits or pain or weakness or whatever it is after surgery. Those are the people that just do a halfway job. They
Yeah.
don't do the job to the best of their ability. And even if they are doing their job to the best of their ability, that's because they're doing what they can do as much as they can do. I wanted to make sure that what I could do to the best of my ability would result in the best possible outcome. I wanted my x-rays of spine surgery to be immaculate. And I learned
Mm-hmm.
that from the Russian spine surgeon that I told you about. I wanted my MRIs, post-op MRIs, to be spectacular. I wanted there to be no tumor left over whatsoever and, taking out as much mass as possible while preserving as much normal tissue as possible.
Mm-hmm.
Neurosurgeon aims to do that. That's not just me. That's not just Dr. Z wants to
Yeah.
do that.
Yeah.
Every neurosurgeon wants to do that, but not every surgeon can implement that. I want to be able to visualize that and then actually execute it. That was my goal. And that's why I thought to myself, I want to be in every surgery possible because the biggest fear that I have is to do an average surgery. I don't want
Mm-hmm.
my patients to walk in and just get a halfway neurosurgery. I want
Yeah.
them to be able to walk out and say, no other surgeon could have done a better job on this surgery. I want to be the final outcome. I want to be the person that other surgeons send patients to when they look at a scan and they say, this is beyond my skill set. I want to be the next level. That's what I mean by that. And so I never wanted to settle for average. I wanted to settle for perfection and excellence every single time.
I'm so glad you talk about this because I don't think a lot of people are actually recognizing this. But like it's yeah, I think every neurosurgeon should aim for that. Like every surgeon, not only neurosurgeons, but everyone who touches and cuts into another people.
Yes, every doctor should aim
Mm-hmm.
for this. I'll venture to say that everybody, period, should aim for
Mm-hmm.
this, no matter what career you're in. If you are a journalist, be the best journalist you can be. If you're a chef, be a Michelin star chef. I
Mm-hmm.
know that I'm just saying this stuff like it's easy, but I understand it's not easy. But that's why I'm saying there's a saying that I live by, aim for the stars. If you fail, you'll land on the moon. The saying doesn't
Yeah.
quite the other way around, but astronomically speaking, it makes more sense. If you say aim for the stars, if you fail, you land on the moon. So that way, if you aim for excellence, even if you don't get the best of the best of the best, you're still among incredible individuals that
Mm-hmm.
have accomplished greatness. And so no matter what it is, just be the best you can be at that thing. And having that mentality will get you so far in life because people will recognize the effort that you're putting in. And I learned that from my oldest brother. I have two
Mm-hmm.
brothers. They're both extroverts, but the oldest one is the one that always told me, ever since I was a kid, he used to always say this to me. He used to always say, if you're going to do something, do it right. Otherwise, don't do it at all. And you don't want your brand, your whole identity to be associated with a job that was halfway done when you could have done
Mm-hmm.
so much more. And if you just strive for excellence and greatness, like I said, even if you don't get to the finish line, that journey is going to take you so far that it's going to open up so many doors for you for other avenues of success.
Obviously, you had a lot of tragedy in neurosurgery. You can avoid it. Do you believe that being emotionally affected by tragedy makes you a better surgeon or a more vulnerable one, the one who will hesitate next time?
Yeah, I need to be careful with how I say this. I'll say this.
Mm-hmm.
I think, I believe there is no room for emotion in surgery, during surgery. And let me explain that. Let's say you're doing a very complex type of procedure. What type of neurosurgery are you interested in? Are you interested in functional, vascular, spine surgery? What type of neurosurgery do you?
Skull base.
Okay, skull base. Let's say you are doing a sellar mass resection.
Mm-hmm.
Let's say that you're trying to take out the mass while you're going transfemoral, whatever. You accidentally nick the carotid during the process, and suddenly you have a torrential outflow of blood, pulsatile. You're losing blood pressure, and you're going to panic. Most surgeons would panic. Most surgeons would be scared. It's normal to be scared. It's normal to be frightened in that moment. But there's no room to panic. There should be no, you can have the emotion without acting on it. And that's what I mean by there's no room for emotion during surgery. You can have the emotion, but you shouldn't act on it. So if you're nervous and frightened, panicking is the worst thing you're going to do, because 100% of the time you will lose the patient. My chairman, no matter what was going on with the patient, when I was training in residency, I've seen some critical situations happen in residency. And my chairman knew how to fix it every single time. And I've never seen him lose a patient in the OR, even though the type of neurosurgery that he does it's not atypical to lose a patient. It wouldn't be out of the realm of possibilities. It should be atypical to lose. Yes. But what I mean by that is that it's not, nobody would be like, wow, how did that happen? It would just be like, wow, I can't believe that happened. That's so unfortunate. That's what I mean by that. So the type of cases that he did was also skull-based procedures. And if there was ever any sort of vascular injury, nobody in the room knew it except the surgeons. Nobody in the room knew there was a critical situation going on except the surgeons, not even the anesthesiologist. And the reason why is because he handled it immediately, perfectly, every single time without panicking. His hand never quivered. He never showed it on his face. You could tell that this is a critical situation and it's frightening, but he knows how to control the room. So if there was a situation where something like that happened, he would stay quiet, he would stay focused, he would identify the source of the problem, put a temporary fix on it, whether it's a clip, putting his sucker on it, putting a patty on it, whatever it is, put a temporary fix on it, and then fix the issue. If there's ever a point where he needs to abort the surgery or whatever, he did it in a very professional, classy, calm way, so that nobody starts panicking. Because you are, as the surgeon, you are a team member, but you are the person controlling the dynamics of the operative. And if your dynamic and your signal and your aura is panic, everybody else is going to panic. That's when things go south. So yes, I do think emotion is important, because you also want to empathize with patients. It makes you a human. But emotions can also cost a life. And it's important to be in control of your emotions. Have them, but be in control of them.
What do you think? How can we get to that level of emotional intelligence, like being this perfect neurosurgeon in these cases? Is there a way you can learn it, or it's just
You can learn it, yes. And I'll tell you how. It's by experiencing the worst possible scenarios and overcoming them. So if you encounter a complication during surgery that you've never seen before, you're not going to know how to fix it. You're going to be terrified. You're going to panic, right? But if you experience a complication and in your mind you start thinking, one time I saw my attending do the exact same thing and I remember how he fixed it, you're going to start doing the same things that your attending trained you to do. The way that you become acclimated to the stress of life and death situations is by putting yourself in situations where life and death situations are frequent. You become desensitized to that kind of stuff. Now, obviously, there's no way to predict when a critical situation is going to happen, right? You can't predict that. There's going to be a carotid injury or transfer node or anything. You can't predict that. But when I was a resident, if I ever heard of anything like that, or if there was ever a situation where a critical event was going on, most people would run out of that room because they're scared. They don't want to be in that room. I was one of the people that ran into the room because I wanted to see how it would be fixed. I wanted to see how I could help. I wanted to be as involved as possible, because that could happen to me in the future. I want to know what to do. So I always put myself in the toughest situations. I always wanted to be uncomfortable, because discomfort will become your new norm. And then when you are in a situation that is average, it's easy. Things flow. You're getting all the right instruments. You're accomplishing the task. And it's just such an easy type of surgery for you if everything goes well. But being in surgeries where things are not going according to plan will callous you and turn
Mhm.
you into a phenomenal surgeon, because then you know how to handle when shit hits the fan. You're capable.
So you speak of stoicism and discipline in these cases.
Yes.
Uh,
Yes.
but what keeps you going in those moments? Let's say, probably, obviously, you had these moments when you neither philosophy nor logic feels enough for you. Like it's so scary for the first time you have a really complicated case, or like.
Yeah. Thankfully, being in residency, you're always available. You always have access to individuals that are much better than you.
Mhm.
And the question is, do you want to be the type of surgeon that is a big fish in a small pond, meaning you
Mhm.
are the best among the individuals around you? Or do you want to be a small fish in a big pond where you are average or less skilled compared to those who are around you? So
Mhm.
in residency, you're a small fish in a big pond. Eventually, you grow in that pond, and then you can become a big fish. And then the goal is to go to a bigger pond where you are then again a smaller fish.
Mhm.
And so if you do encounter a scenario where you have something that goes unplanned, you have someone who has more of a skill set than you do to be able to call on. You can work at a facility where you have colleagues that are vastly more experienced who can come take a look. Sometimes, unfortunately, in neurosurgery, depending on the type of error, if it's an egregious error, there is no repair. There is nothing you can do, no matter how
Mhm.
experienced you are. You can't come in and, unscrew a situation that you screwed up really badly, right? But if you have a colleague who's seen this before, they might think of something that can at least mitigate the situation and not really reverse it, but maybe just make it a little bit better. And if it's a critical life and death situation, then of course, immediately you have to get as many people involved as possible, no matter who it is. Experienced or inexperienced, you need people in the room that can kind of contribute somehow. I'm not saying bring a medical student in and have them panic. That's not what I'm saying. Other people who are specialized show up and kind of uh, do their part in any way that they can so that collectively you have a more favorable outcome, ideally.
And let's talk about spine surgery a little bit because it's something interesting.
Yes.
The phrase carefully selected patients is everywhere in guidelines, and it's rarely actually defined what it really means. How do you personally interpret it in your decision making in practice?
Look, in spine surgery, you have to be extremely careful. A lot of times it depends on the type of surgery that they need. So if they need a large deformity correction, like a
Hmm.
scoliotic deformity correction, it's probably not feasible to do it on an individual that is 85 years old, that is on blood thinners for cardiac bypass, and has osteoporosis,
Hmm.
and they're a smoker. Like, that's not the type of person you want to do that surgery for. The way that I interpret a person's um, readiness for surgery is by, of course, looking at all their comorbidities, age being one of the biggest ones. And, geriatric spine surgery is starting to become a thing now where more and more surgeons are operating on older and older people because we're living longer and longer. And you can be a young 75 or 80. You can be that. I've seen that. I've seen a
Hmm.
young, which sounds kind of, like an oxymoron. But I've seen a young 80-year-old where they
Yeah.
come in the clinic and you look at them and they look better than most 50-year-olds. And you're like, clearly take very good care of yourself. And those are the individuals that maybe age is not the biggest factor, right?
Hmm.
But then you also want to consider other things. Are they a diabetic? How's the wound getting healed? Do they smoke? Are they going to fuse if they need a fusion surgery? Are they going to get up and walk after surgery? That's another one that I really look at tremendously because there's several studies that have been done that have assessed a person's outcomes based on their own perception of how they're going to do after surgery. And so what I mean by that is the individuals who are eager to get better and the individuals who want to get better clinically are the ones that do get, because they're the ones that want to get up. They're the ones that want to work with physical therapy. They're the ones that want to heal and be functional. The worst thing you can do after spine surgery is stay sedentary, unless you're told to stay sedentary for whatever reason. But staying sedentary for a long, the people that feel bad for themselves, that feel sorry for themselves, those are the ones that tend not to do well. And so those are the individuals that typically have a poor outcome. And so it's critical and crucial to kind of recognize that early on. And being in California, I worked with an attending that was incredibly selective of his patients, very selective. And he had virtually a 100% amazing set of outcomes, 100%. I've never seen that before. In surgery, it's okay. It's not that it's okay, but it's not uncommon for some patients to come back and be like, the surgery didn't really do much. That's not really uncommon. I'd say the vast majority do very well, but you wouldn't be really shocked if somebody comes back and is like, you know what, that back pain is still there. Then it's like, okay, well, then we got to try something different. For this particular individual, this attending, 100% of his patients came back and always said, I feel better. And I've learned why that is. And I've asked him that several times. I said, how do you know? How do you know what patients to operate on? And one of the things that he told me was exactly what I told you, is that when you're sitting down and you're talking to the patient and you're getting their symptoms, a lot of their behavior, their mannerisms, the way they carry themselves, you can tell who's going to do well and who isn't. The ones that are pessimistic are likely not going to do that well, but the ones that are eager to improve and work hard, those are the ones that tend to do better. And so among the medical stuff, one of those things should be a patient's outlook and perspective.
And we also now live in like a kind of culture, let's say, that is conditioned to expect zero pain after spine surgery.
True.
How do you manage patient expectations about this pain?
It's a great question. And honestly, I do it in the beginning. When the patient comes in, one of the questions that I ask, if we're going to do surgery, one of the questions I always ask is, what is your goal for surgery? What do you want to get out of this surgery? What is ideal for you? What do you want to see happen? And more often than not, they say, I want to be able to live my life again, or I want this pain gone. Or they say something a little bit more abstract, like, I want to feel young again. I want to feel, like I can contribute in my relationship to, my wife and my family. I want to go back to work. They have realistic goals. The individuals that come in and they say, I want the pain gone, or anything like that, you have a conversation with those individuals. You tell them, you say, listen, the pain isn't never going to be gone. It's possible that it's going to be gone, but I don't tell them that because I don't want them to hang their hat on that. It's possible that the pain can disappear forever. I told you my dad was one of those. Thankfully, knock on wood. But again, that is the exception, not the rule. And what I tell patients is, let's say right now your pain is 8 out of 10, hypothetically, let's say 8 out of 10.
Yeah.
You have surgery, your pain is likely to go down to like a 2 or a 3. It's not going to be a 0. You're going to have discomfort, most likely forever, but it's not going to be debilitating discomfort to where you can't get out of bed and you can't go for a walk. You can still go for a walk. You're going to notice it. You're going to be like, hey, it feels like I, did back day yesterday or whatever it is, it's sore. But the goal is not to eliminate pain. It's to restore your quality of life and your functionality. That's the goal of spine surgery.
And what do you think the public really wants from doctors on social media?
They want accurate, realistic information that is unbiased by finances. They want to know what you really, really, really think. And They don't want sponsored posts. They don't want a post that, insurance companies are going to want to hear or anything like that. They want to know the absolute truth. And they want to know what's most likely going to work for them. That's what I think
Mm,
people really want to see. People kind of come to doctors on social media because they have a problem they want to fix, or they are curious about medicine. So my platform is mostly about education, and I
mhm,
talk about several different disease pathologies, and I kind of make educational videos about it. Not a lot of my videos, some, but not all, are about treatments of these things. It's more about
mhm,
explaining why they happen, what they are, who gets them, what are some things you can do to prevent it, or if you have it, if there's an option to prevent it, right? But my platform is mostly for education. So some of those
mhm,
individuals are just here because they're curious. They're curious individuals that they just want to learn. But sometimes there are people that have a real problem, and doctors have just dismissed them, and there's
mhm,
nobody that wants to listen to them anymore. So they're looking for answers. And so they just want an unfettered, true perspective of what a doctor thinks. If I could show you my email, you would be shocked at how many patients reach out to me asking for help because doctors have not given them an answer. And I wish I could sit
mhm,
down with this individual and just kind of look at their images and hear their symptoms and try to help them figure it out. But number one, legally, I can't do that.
mhm,
Number two, if if somebody has already tried to figure out the problem
mhm.
and hasn't been able to do so, and then you go to another person and then they can't figure it out, and then the third doctor can't do it, and the fourth doctor can't do it, then it becomes less and less likely that the next doctor is going to be able to do it because we're all trained in a similar fashion, not the same fashion, but in a similar fashion.
Mhm.
Most doctors have the same type of foundation of knowledge. Obviously, we specialize in different things, but we have the same foundation. So most doctors will look for the same things. A patient comes in and they say specific buzzwords that you learn in medical school. You're going to start to recognize those buzzwords and then start to, look for that
Yeah,
diagnosis. But if the same doctors are not able to figure out exactly what is going on, well, we all have the same training. So it's not likely that you're going to find somebody that is able to do it. There are some circumstances where you have very gifted people that are just able to kind of pinpoint a very subtle symptom and connect it to another one. And maybe sometimes they can say, you know what, let's try this. And they can figure that out. That's a little tough to find somebody like that because every doctor has that skill set, but in different aspects. I can remember a couple times where I had a slam dunk diagnosis that nobody else thought of when I was in residency. I can think of a couple times where I was very humbled because the diagnosis was right in front of me and I missed it. But it really matters to get the opinion of others. But then if you're just not getting an answer, you got to start looking elsewhere. And then I think that's when patients start to come to social media.
that's great. Thank you so much. I'm so glad we covered everything with you that we planned to, and it was a really beautiful conversation. Thank you
Had a
so
great
much.
time. Of course. Thank you for having me.